And now it's open for question. I think Professor Majdi Idris with us. Can you put him live? So, do you have any question for Dr. Muhammad or Dr. Majdi? Yes, please, Dr. Atiyah.
So my question for Dr. Majdi, I have a patient with SLE and she is active SLE. And when we started her on belimumab to treat her symptoms, after 3 months of therapy, the patient failed belimumab, but she presented by exertional dyspnea. And when we screened the patient, she had pulmonary hypertension by right side catheter, and currently she's in dual therapy. So the question was, is it?
The question, is it related to belimumab or?
Disease activity. We stopped the belimumab, but patient didn't improve it.
So after discontinuation, no improvement, yes?
Okay, she still have but when we check the literature, there is no reported case. As an expert in the field, have you ever faced pulmonary hypertension?
Like biological. Belimumab is one of the biological therapy. We use it to treat lupus.
Thank you so much. So that's a very interesting question. Now we know that lupus itself can cause pulmonary hypertension, and it's kind of unique pulmonary hypertension because it is very different than SLE. Most patients, when they develop pulmonary arterial hypertension with lupus, that's because of the active inflammatory vasculopathy in their pulmonary vessels, and a good number of them will actually significantly improve, and the pulmonary hypertension could be actually cured after aggressive immunosuppressive therapy. So it's one of those very few entities that you can cure pulmonary hypertension if you control lupus, and some of those patients you can even withdraw treatment. Now, regarding to biological therapy and whether biological therapy can cause pulmonary hypertension, I think it's really early to say if they are definitely causing pulmonary hypertension or not. However, there is few reported cases of basically pulmonary hypertension associated with some of the biologics, including the biologics that's used in bronchial asthma, for example. But this is very, very early or really premature to say that this is for sure directly caused by the biologic or not. We know that basically some chemotherapeutic agent can cause pulmonary hypertension for sure. But I think for biological therapy per se, it is still early to say, although we've noticed a couple of asthma patients develop basically pulmonary hypertension, but it's very early to say that this is caused by the drug itself, or this is just a coincidence. And especially in your case, after stopping the drug, the patient did not improve. So I would assume that the pulmonary hypertension was lupus-induced rather than medication-induced.
No.
I hope you answered the question.
Second question?
Yeah, thanks.
Maybe you can, Muhammad, you can use this microphone.
I just noticed in the Kogelan study that you presented, they check the uric acid. Can you just tell us what the point of uric acid in pulmonary hypertension?
Yeah, that's a very good pickup because many people actually pass this. Definitely uric acid is a surrogate marker for cell replication and cell death. Now, what happened in pulmonary arterial hypertension when we talk about PAH group, that there is continuous cell proliferation with blunted apoptosis. So basically, unlike the normal situation when you have a new cell develop every day and similar number of cells die every day, in really pulmonary arterial hypertension, very similar to cancer, you have continuous cell proliferation with the blunted apoptosis. So the uric acid is just a marker for an active cell proliferation mechanism that can happen in pulmonary arterial hypertension. And actually, it has a prognostic advantage. So those patients who came with quite high uric acid, they have a poor outcome, very similar to the pro-BNP level. But that was a really good pickup.
Yes, Dr. Amir, thank you for your presentation. Me, أرفع لك القبعة to touch every tender area and in the raw land in the field. Thank you for this and your team. My advice, and correct me if I'm wrong, we should not put the concentration of reproductive health into pregnancy and management during pregnancy. The quality of the life and sexual education for the patient is essential, that especially we are dealing with the diseases that can affect the childbearing period. So in your institution and faculty, do you have educator, sexual educator, male and female, or do you have pregnancy clinic to refer the patient as a routine for all patients with SLE, with rheumatoid, to educate the patient about sexual education and how they can enjoy their life away from pregnancy?
Thank you for your question. Now, in our institution, sexual education has been mainly in the urology clinic. Now, there is a subspecialty that is called sexual medicine that is mainly taken by colleagues from urology, OB/GYN, and family medicine. And we have, maybe our institution, we have 3 or 4 colleagues who have this subspecialty. Now, sexual education has been a taboo that nobody talks about in our conservative culture, but the issue is that many people are suffering, and because they cannot have the adequate advice, they suffer in silence, the partner suffers in silence, and the marriage cracks over time, especially if the woman is the sick one, because there is always a pressure on the husband because he can marry another woman. To me, whenever I see one of my scleroderma patients who her husband was usually coming with her and then he misses 2 or 3 appointments, I always ask, كيف حال زوجك؟ فين وما بيجي معاكي? Just to make sure that things are on the track. Now, what I can promise you is that I have actually talked to our social workers في الجمعية الخيرية and the charitable association, that we are going to start a patient support group and discussing sexual problems in small groups of females so they can share their expertise. We luckily have a colleague who is specialized in qualitative research. You know, qualitative is patient interview, and then the data are put in a software. You can see themes of problems, and then you can put recommendations based on that. It's not like having a survey and having p-values and percentages and means. So again, we have the IRB for this study, and we're going forward through this project. So we're having a service provided for patients through the charitable association, so you're free to refer your patients. And we're also having a research where we can
we broaden the spectrum to catch psychology and psychiatry in this team, because urology is always, they are surgeons, they are busy, they give advice and nothing else. But with psychology and psychiatry, they are more qualified how to communicate. This is personal experience.
Well, psychiatry and dermatology are the 2 specialties that I will tell anyone here good luck in getting them involved, because they are limited and they are very busy.
Thank you, Dr. Magdi. Thank you, Dr. Amer, for the informative talk. My question for Professor Magdi regarding the uric acid as a risk factor. In the DETECT study, they included one of the parameters. And as you've mentioned, it increased the proliferation of the cells and also it can affect the acetylcholine-mediated vasodilation pathway. So would you consider using urate-lowering drugs in those patients with pulmonary hypertension?
Oh, thank you so much. This is really very interesting point, and I'm not sure that this was really tackled in clinical trials, because at the moment we look at the uric acid as just a surrogate marker for really cell proliferation and not as a cause for the pulmonary hypertension. So really lowering uric acid per se is, well, I have to say that without really evidence, is basically unlikely to improve the pulmonary hypertension, although it might have another impact on the other thing. This is rheumatology meeting, so we have basically gout, etc. But for the pulmonary hypertension, I'm not aware that there is anyone who really look at this to be basically trying to lower uric acid per se, and whether this will have an impact on the pulmonary hypertension. I think the rationale at the moment is to treat pulmonary hypertension and then look at the uric acid level coming down. Very similar to the pro-BNP. When we have high pro-BNP, simply we don't treat pro-BNP, we treat the cause behind it, and then we look at the drop in pro-BNP as a marker for improvement. So as we speak now, what we are doing is really treating pulmonary hypertension and follow uric acid level coming down, ensuring us that this patient is getting better. But I promise you, I'm gonna raise this point with our next pulmonary hypertension meeting and see if people will have a different opinion. So that was a very good point. Thank you for sharing with us.
Thank you.
Can I comment on this uric acid thing? Just to, this is actually the most asked question for the detect developer in all meetings that I have attended. Uric acid has been always the problem for every rheumatologist. I'm just gonna tell you that uric acid is just a noise. Whenever you have a disease and you have a biomarker that is elevated, you want to know, is it really part of the pathogenic pathway and its blockade will lead to improvement, or is it just noise? And when you do cytokine studies, you're gonna see a lot of elevated cytokines that are not related to the primary pathogenic pathway. If you block them, you're gonna actually cause problems. So uric acid is just a surrogate of endothelial hyperplasia or proliferation, which is associated with pulmonary hypertension. And I don't believe that uric acid is pathogenic. The increase in uric acid is not really pathogenic in the status of pulmonary arterial hypertension. But again, maybe I will be proved wrong, and maybe adding uric acid might really change some parameters.
Thanks, Dr. Majdi, for the very interesting lecture. And my question is for Dr. Mohammed Omer. Thank you for the very interesting lecture. You always highlight a challenging point in the medical rheumatology practice we see and we may see. Dr. Omer, we have a lot of patients. They are lupus, mixed connective tissue disease with pulmonary hypertension. They get pregnant after we counsel them for the high mortality morbidity. And being on Imuran, small dose steroid, as we know that the pregnancy and pulmonary hypertension has a high risk that the patient may get PE. So the use for the anticoagulation is controversial in a patient with pulmonary hypertension. What about pregnant lady with pulmonary hypertension?
Okay, so let's take one point out of the way. Giving anticoagulation for systemic sclerosis patients who have pulmonary arterial hypertension is associated with the increased risk of bleeding and mortality.
Yes.
There was a systematic review that was published, and just anticoagulation for the reason of pulmonary arterial hypertension is associated with increased risk of bleeding, because scleroderma patients have telangiectasia everywhere. They have this increased vascular resistance, so we would not really give anticoagulation unless the patient has a clear thrombotic indication. So we'll take this out of the way. Now, what I was saying here, it might be really a very difficult thing, is that patients with systemic sclerosis who are in their early 40s and they have pulmonary arterial hypertension, there are many things that need to be considered, and always the health of the patient is more important than bearing a baby or having a baby. And you cannot really continue the pulmonary hypertension medications. You cannot really taper them down or changing them, except maybe for sildenafil. And maybe Dr. Majdi can go into this very challenging conversation. And therapeutic abortion is what we really advise our patients. This is for moderate to severe pulmonary arterial hypertension. If a patient has a mild form, has been doing very well for a long time, and you might think that she might improve, you might consider tapering the pulmonary arterial hypertension medication and then see what happens. But there is always a risk, because the changes in pregnancy will lead to increase the pulmonary pressure and hence causing more problem. And pulmonary arterial hypertension is a fatal disease. Remember, it's a fatal disease. It's worse than cancer. If a patient with breast cancer who wants to get pregnant, okay, and she has a risk of metastasis, it's a big no for the oncologist. Dr. Majdi, do you have any comments?
Yeah, thank you, Dr. Omer. So basically, as you said, that basically this combination of pulmonary hypertension and pregnancy are really very bad combination. And the mortality used to be reaching 30 to 50%. Now with the modern therapy, the mortality is about 7 to 9%. So we're doing better with that, with the current basically management protocols. So, but definitely, I totally agree with you that we always recommend, and I keep saying recommend, the decision at the moment belongs to the patient herself. And then we need to deal with her decision as a physician. We always say, please don't, we recommend that you don't get pregnant because there is this kind of 8 to 9% increased risk of mortality. And again, as Dr. Amir said, we cannot use all medications. So if somebody is, for example, on basic lithium receptor antagonist, bosentan, macitentan, that has to be stopped before pregnancy. And the two drugs that we can use during pregnancy are basically sildenafil, tadalafil, or prostacyclin. So most of those patients, what we do, we really put them on maximum dose of sildenafil, and we start prostacyclin therapy, and we follow them closely during the pregnancy. Most of those patients, they have right heart cath just before pregnancy to determine what's their level, and it would like them to have good hemodynamics before they became pregnant. If they became pregnant, then we work very closely with the cardiologist, with the obstetrician, and with the intensivist. We plan delivery by C-section around 34 weeks. So we don't let them to reach term, and then has to be done in under control situation. In our experience, we have about 5 pregnant women that they all survive the pregnancy, but that's not to say that we really allow this. The recommendation is still, this is high risk, and the mortality, of course, 9% is better than 50%, but it's still high enough to say that this is a very high risk decision. So that's a really tough case scenario, but we have to deal with it sometimes. If you have a young lady who wanted badly to become pregnant, and we just say, okay, that's your call, and we'll try to help you through your pregnancy.
Yeah, thank you, Dr. Majdi and Dr. Amir, for this very nice and informative presentations. Dr. Majdi, just I want to share you one patient that I had. Unfortunately, I catch her up while she is pregnant in the first month of pregnancy, and unfortunately, the echo came with pulmonary arterial pressure of 30 to 35. I'm not sure how accurate is the echo as a screening tool is enough for conclude in the issue of pulmonary hypertension, and I'm not sure whether we need to further proceed with the right heart cath in such patient, and how safe is it. This is number one. Number two, I'm not sure whether are you going to decide termination of pregnancy or at which zone of risk stratification, or from day one, since you find this pulmonary arterial pressure of 30 to 35, you will decide about termination right now? Thank you very much.
Thank you so much. Very, very good question. Now, the first question is the role of echo. And again, we keep saying that echo is never the diagnostic test for pulmonary hypertension. Echo is only screening tool. And if you want to really diagnose pulmonary hypertension, we need right heart cath. As a matter of fact, we need right heart cath not only for diagnosis, but also to understand the hemodynamics and to sub-classify the patient into the 5 groups that we did talk about. So if you have an echo with really pressure of 30 to 35 in pregnancy, that's kind of really basically challenging. That's kind of borderline. That's reflected TR velocity about 2.8, which is not too high really. But if you have clinical symptoms and this echo, you have previous echo which was normal, definitely you need to go for right heart cath. Even in pregnancy, it is really safe, and it shouldn't cause basically any trouble in experienced hand. So yes, that patient probably deserves right heart cath if she decides to continue in her pregnancy. If she, of course, agreed to terminate the pregnancy, then definitely the earlier the better, and we recommend termination within 16 weeks of pregnancy, not after that. So if we can do it earlier, basically the better. But echo alone, we will never start treatment or build a PH strategy based on echo. So we always confirm it by right heart cath.
Okay, thank you, Professor Majdi. Thank you, Dr. Muhammad. It was a very interesting session. So we'll end here. I think according to the program, we passed the coffee break. So we'll start the 3rd session right now. The coffee break is right away here in the this area near Dubai. So you can bring your coffee if you want, and we'll start the 3rd session. 5 minutes? You want 5 minutes rest? Or 10 minutes? But it will take from the schedule. So we will be back here exactly at 11:30. الناس قاعدين. I think no need. الكوفي break هنا. خلينا نكمل. Just 5 minutes if you want to bring some coffee, and then we'll continue. So we'll start after 5 minutes exactly. Huh?